behalf of myself and my co-instructors and dignitary who is going to present keynote address, Dr. Alok Sharma. I welcome you all here, and indeed it's a honor to have Dr. Alok Sharma here, and he's going to take up a very challenging and interesting talk. Sir, please.
Thank you, Colonel Parihar. I'm talking about those people who have listened to this last talk before this. Steve mentioned about eye stents. Now, I'm talking about MIGS eye stents. And the most interesting part about my talk is that I'm a comprehensive ophthalmologist. And what is my perspective as general ophthalmologist? And I guess there will be lots of general ophthalmologists who are not glaucoma specialists. They want to know how those things work. So, and my talk is my experiments with truth. Now, I live in Wagga Wagga. It's a friendly city about 450 kilometers from Sydney. That's my practice, solo practice. I'm not a glaucoma specialist, that's my declaration, but I do plenty of other surgeries. I do squints, I do cataracts, I do plastics, I do injections. So I'm very busy, and I want to look after my patients with the latest things. I've tutored the registrars as well. I don't have any financial interest, and I do acknowledge Glaucos, who have helped me get some slides. Now, I'm sharing my 2 years experience. In Australia, we've been lucky that we have had eye stents for the last 5 years. I'm a mid-stage starter. I started in 2017. And how does it affect the busy of general practice? It is for general practitioners, not for the glaucoma specialists. Now, I graduated from Rohtak in 1990, and that's what we had in 1990. There was hardly much we could do for glaucoma. So neither patient knew much about it, nor the doctors knew, and glaucoma wasn't very well understood. Now, in this world, we have got so much which is happening. In 2020, we got ablation tonometry. We have got mind-boggling technology around us. At the end of the day, why are we doing all this? We are doing it to look after our patients, right? And now, the losing sight from glaucoma is a taboo. And there are medical, legal, and economic perspectives of that as well. So we have to take that into account. We are in the smart technology world. So time is the most expensive commodity. Neither doctor nor patient has time. We want quick, good, and reproducible results. So, and vision has got serious socioeconomic implications. And obviously, if you look at it, there was $1.9 billion which was spent because of the glaucoma, and annual cost is likely to be $4.3 billion in 2025. So it's got a big role to play. Now, what's the problem with the standard treatment protocols, laser, invasive surgery, and glaucoma? These are the things, but with the drops, there is corneal surface damage. There's non-compliance. More than 90% of the patients are non-adherent. More than 50% stop taking drops, because this is one condition which doesn't do anything to you. You know, if you have got a tummy upset, you got pain, but people don't understand it. So it's an important thing. Less durability of laser, risk from the invasive surgery, cost burden. 1 in 5 patients in US have been noted that they are on at least one drug. So while we do cataract surgery, how about have something which we can do at the same time, and which is, there's no additional comorbidity. So there is enough evidence to show that eye stents work. It's surgically easily trained. It can be done in cataract surgery, and I call it an additional modality to treat glaucoma. Now, there's enough data online which we can read, and it needs to be evaluated whether it is a standard of care. Now, the eye stents were the first MIGS. So eye stent and eye stent inject, which you are going to be getting, it's coming to Australia, to India in about April this year. Now, it improves the outflow through the conventional pathway, and these are the two eye stents which you see here. So the one on the top is the the iStent, and that's the next one is the iStent Inject. The second one is the much more easier to use, and if you can see that it's the smallest implantable device in the human body, and it is non-ferromagnetic titanium, and it is heparin coated, and it is MRI safe. Now, this is what it looks like. So we basically are targeting the inferior nasal part of the trabecular meshwork, where we have got maximum number of collector channels. So we inject about 2 of these. Purpose, the therapeutic aim is to reduce intraocular pressure, avoid serious complications, spare the conjunctiva and sclera, and safely preserve potential for future treatment options. And that's what we have. That's what the iStent looks like. And there are 2 preloaded iStents. It's sterile, and it is injected into the trabecular meshwork. And there we have got about 3 shots which can give. Now, indications are mild to moderate glaucoma, and like ocular hypertension are very good. But these conditions like primary and secondary angular closure glaucoma, neovascular glaucoma, retrobulbar tumors, thyroid, Sturge-Weber syndrome, these are not the indications for, they are contraindications. Now, 5 key points is to understand the anatomy of the antechamber. We understand how to achieve optimal visualization, understand iStent product, and understand implantation, and understand the surgical procedure check. Now, this essentials which we need to know is we should be good at gonioscopy. They have website there, www.gonioscopy, and in India, it's very well taught, gonioscopy. So we can really learn gonioscopy. Surgical, the most important, another important is surgical proficiency with phacoemulsification, good microscope, enough of dispersive and adaptive viscoelastic, 20 surgical gonioscopies we need to do, wet lab dummies, and always have extra stents as a standby, and under promise and over deliver. Don't use it as a business gimmick. Oh, we'll get rid of drops. No, don't use that. It's just one of the modalities. Now, this is my real time. So this is all the things which I have done myself. Right? I did clear corneal cataract surgery. Fill the AC after doing the cataract surgery. Fill the AC with the viscoelastic. Put the lens in, and you can constrict the pupil with Miochol, but I don't think it's really required. Now, we tilt the patient head of the patient about 35 degrees away from us, and shift the microscope about 35 degrees towards us, and increase the magnification. That's how it is done. And you can use, with the surgical gonio prism, you can use a scleral clip which can stabilize the surgical lens. We put viscoelastic on the cornea and position it. This blue thing is to retract the trocar, and black is to implant the iStent. And if you can, in the iStent, you can see the trabecular meshwork there. And inferior nasally, where there's more blood, red area, that's where the collector channels are. As soon as we inject it, shoot it, you get a plume of blood comes in. You put up 2 of them there, and you can see blood in the AC, do irrigation and aspiration, and that's the finished product on the side. Now, and that's how it looks. There's nothing obstruction in there. So quickly I'll tell you my single surgeon's perspective, right? So I saw the patient of day 1, 3 months, 6 months, 12 and 18 and 24 months. I never stopped the drops immediately after the operation. I called them in 3 months, and then I asked them to stop the drops 3 weeks before coming to see me. I had patients of every type, POAG, OHD, normal tension, pseudoexfoliation, and I had a good distribution of patients with all different refractive status as well, because we say that if we have got shallow AC, narrow angles, and when you take out the cataract, it will open the angles, the pressure should come down. Now, this is my results here, which is astounding. Preoperatively, 51% were on 1 drug, 32 on 2 drugs, 10% on 3 drugs, and 7% on 4 drugs. And there was 10% reduction noted in all the patients. There was 11. Now, the medical burden. So some of the people who are on 4 drugs, and they are not even on 1 drug, And I'll just get back to the last slide, which is very important. I'm sorry, we are running out of time. For 12 months consistent cohort, we saw that the average pressure was 17.1, and it was reduced to 15.3. And 12-month cohort, which we saw that in 37 patients which have been followed up, the drops came down from 1.9 drops to 0.2 drops. Hence, the medical reduction is from 1.9 drops to 0.2, which is 89%, which is incredible results in my opinion. And 76 patients were medicine-free, as opposed to 0% free preoperatively. 0% were on 2 drops, while before operation they were at least 51% preoperatively. So it is, I think, is a good result. In conclusion, what I feel is that iStent is a very good modality we should keep in our armamentarium, right? It is well tried, and being a solo surgeon, I feel it's worth considering. Easy, simple to use, easy to, there is a cost factor, but if more people are using it, the cost will come down, and it is good. And most important thing is, while you're doing the cataract surgery, you can do it, and it's an excellent modality for the cataract surgeons. And lastly, we invite you to come to RANSCO and the World Ophthalmology Congress. And while if you have any questions, if at all, so I can play the video. Sorry. Yes, that's a very, very important question. The cost is about $1,600, right? But which is, if you look at the Indian terms, 70 to 80,000 rupees it will be coming up to. But the thing is, you see, this is the cost when only 3 or 4 countries are using. You know, I mean, we started in 5 years back, right? Germany started 5 years back. Canada started 5 years back. 40% of the ophthalmologists are using in Australia. US, it started last year. UK started last year. And India, it's going to come here in April. I have got a follow-up for 2 years, right? And there are lots of studies showed in Australia where it has shown excellent results.
So this, it is being sustained, the IOP reduction, for
Yes.
at least 2 years?
Yes, for 2 years. So, and there's those people who are on 4 drops, there's not even a single person on 4 drops now.
And any complications?
Day 1, there is raised intraocular pressure. There could be hyphema, but those things are things which are technical things which we learn. Because what we used to do is, as a tradition, we try to make the eye soft after the operation. In this, you don't leave the eye soft. You make it firm. If you keep it firm, after doing the AC and doing the blood washout, because after when you put anything in scleral trabecular meshwork, there will be blood coming out. So if you clean it very well, keep the pressure high, it will be perfect, right? Later on, there's not even a single complication I have experienced. Nothing. Yes, initial times, when you don't indent properly, when you don't do these things, it could come out. So there's a very easy way, if there's a viscoelastic, it can easily rethread. So with the amount of surgeries a good surgeon does, it took me, I've done like 75 cases now, right? I have not encountered any complications. My maximum day 1 pressure has been 35. And those people I knew why it happened, because I kept the eye soft and there were blood in the AC. That's it. But with experience now, I don't have any problem.
Was there so much hyphema that you would do a washout or something again later or something like that?
No,
Resurgery or something?
I never have to do AC washout, because the reason behind that is because some of the people are on aspirin, right? Anticoagulants, So it's almost like putting a cannula in the vein, right? So if the blood has come out, right? If I try to go and wash out, we come back to the same point. It can rebleed again, right? Sorry.
We are exceeding